بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أبناء الطلبة، أرجو من الله العلي القدير أن تكونوا بصحة وعافية وأن يحميكم من هذا البلاء إن شاء الله. Our lecture today, the management of upper gastrointestinal bleeding or hemorrhage. We want to know from our lecture, we should know the introduction of upper GIT bleeding and the principle of management that include the diagnosis and the treatment. Now, what's mean by upper GIT bleeding? It defined as any bleeding from gastrointestinal tract proximal to the ligamentum of teres, and it is a common cause of emergency hospital admission and account for about 5 to 10 mortality, which increase in elderly. That means when you are a doctor in the emergency department, many of you will face this problem in the outpatient or in the emergency department. Ligament of teres, and usually what are the mode of the presentation? Patient with upper GIT, how present to you? It is usually present either as a hematemesis, which defined as vomiting of the fresh or old blood proximal to this ligament, which is usually bright red. That means it might be a significant bleeding, or it might be a coffee ground emesis. That means it is an old altered blood which is not active bleeding. Or the patient, it can present to us as a melena, which defined as the passage of a black and foul smelling stool, and usually it comes from the upper part of the GIT. Now, or hematochezia, that means it is passing of the fresh blood from the rectum. That means it may indicate that it is a severe bleeding. Sometimes it is difficult to differentiate it from the lower GIT bleeding, in which there is a passage of the blood from the rectum from the lower part of the GIT. Now, how we deal with this patient? If I receive this patient, the casualty, first of all, I will immediate assessment because it is an emergency. Second stage, after that, I will have a stabilization of the hemodynamic state of the patient, and I will identify the source of the bleeding so that later on I can stop the active bleeding and I will treat it, and later on I will prevent the recurrent bleeding. How we assess of this patient? That means I will take a full history as rapid as possible from this patient. For example, if he has a cardiovascular disease or he have an respiratory disease that might worsen the condition of the patient, with rapid examination for this patient. Severity of the bleeding can be determined by level of consciousness. Any disturb of the level of consciousness, especially in old age, should suspect that this patient have a severe GIT bleeding. If the pulse rate is more than 100 beat per minute, or the patient have a postural hypotension. What is postural hypotension? That the patient, when are standing up from the sitting position or the flat position, the patient feel a feeling of a dizziness or feel on the ground. Or the patient have severe type of the bleeding. It's usually in the later stage, in what we called it a hypovolemic shock. The patient start to develop a slow pulse. That means a bradycardia. Now, I'm a doctor. What is my job in the casualty? First of all, aggressive resuscitation depends on the bleeding severity. Inadequate resuscitation, it might lead to multi-organ failure. And resuscitation, usually, first of all, I will try to ensure a patent airway and breathing for this patient. Second, elevation of the foot of bed to about 50 degree. Then I will put an IV access. First of all, I take a blood for blood group and cross matching and prepare a blood for this patient because this is an emergency, and then I will send him for investigation that include PCV, urea, electrolyte, creatinine. It is very important for the renal function, a platelet count, and liver function test. Now, if I take this blood, what I will do? Shall I leave on the patient waiting for investigation? No, I will start to give the patient IV fluid. We call this a crystalloid liquid or fluid in form of normal saline, ringer lactate. I will give him for at least 1 liter over 30 to 45 minutes. Then I will put a catheter for this patient and to empty the bladder, and later on to measure the urine output, which is very important and sensitive way to know whether this patient have a pre-renal failure as a result of the hypovolemia from severe bleeding. Also, the input of the fluid and blood, it will depend the amount of the urine output for this patient. Then I will put a chart for this patient. I will measure it for blood pressure, pulse rate. Sometimes I put a central venous pressure and the urine output to determine the rate of the infusion for this patient. Oxygen, it's very important for this patient. Supplement of the oxygen, it is very important to enhance the carrying capacity of the blood. Later on, what I will do, I will put NG a tube, a nasogastric tube for decompression and prevent of the aspiration, because most of those patients, especially if they have an abnormal level of consciousness, he might be unconscious, so that they are liable for aspiration pneumonia. Sometime I will treat the bleed and the bleeding stop, but the aspiration pneumonia, it is very difficult and it might lead to the death of the patient. Then I give the patient a cold saline lavage, and later on I will give a blood transfusion. A transfusion, there is a special indication. Not all patients with upper GI bleeding should be given blood transfusion. The indication, the first indication, when there is a significant blood loss, or there is a PCV less than 30, or there is ingoing bleeding or inadequate response to fluid resuscitation, and in elderly patient and the present of the cardiopulmonary disease. All those patients, they are indicated for the blood transfusion. Sometimes I start to give the patient sedation to quiet the patient. Then I will take a rapid history from the patient for the cause, comorbidity, and the character, onset, volume, frequency of the bleeding. That means I will ask about the history of the melena and the hematemesis, for how long, how many times per day, and the frequency, the amount, the color, the content, and etc. And also, there is a careful examination may yield, but it is usually, sometimes it is not important, because not all examination of patient with upper GIT bleeding will give us the exact cause for this upper GIT bleeding, and it is usually found only in 50%. In the history, it is very concentrated on some points, sometimes would give us a clue for the cause of the upper GIT bleeding. For example, if the patient has a history of peptic ulcer disease, or he's an alcoholic, or the patient take non-steroidal anti-inflammatory drugs, especially in old patients, those with osteoarthritic changes or with joint problem, or any history of dysphagia. Now, what are the common causes of patient with upper GIT bleeding? We have duodenal ulcer, gastric, etc. And there is a less common causes, for example, of the esophagitis and so on. Rare causes: duodenal tumor, aortic, enteric fistula, blood disorders, hereditary telangiectasia, and on examination, what we will see, there is no specific. The patient have sign and symptom of anemia or hypovolemic. That include pallor, sweating, cold extremities, and we examine for the nose and the pharynx for any local cause which might be the cause of the bleeding, and sometimes we find epigastric tenderness. Also, when there is a collapse of subcutaneous vein, tachycardia, hypotension, restlessness, or sometimes the patient is already a known case of a chronic liver disease, and as we know, patients with a chronic liver disease, they are liable for upper GIT bleeding from the bleeding from the esophageal viruses because of the portal hypertension, or coagulopathy that result from the hepatic cell disorders. Or it might be the patient have a gastric carcinoma, and from this patient on examination we found this patient have a mass on the abdominal examination, or supraclavicular lymph node enlarged, especially on the left side. After that, what we do, and what we call Rocal's score. We do a score for this patient to decide what severity of this patient we have. According to the age, shock, comorbidity, diagnosis, we put on a score for this. According to this, we can classify this patient into three major groups. The high, that means this patient have the score more than 5, intermediate 3 and 5, and low risk 0 to 1. One asks why we do this score. What is the important? Because our management, it will be depend on this. For example, those patients with low risk, usually 80 of patients, they are recovered spontaneously without medical treatment. Just we give the patient proton pump inhibitor, for example, omeprazole, and hospitalization for 24 hours, and maybe discharge if there is no complication for this upper GIT bleeding, and the bleeding will stop. For those patients with intermediate risk, the same treatment. Also, the patient give the patient proton pump inhibitor, but the hospitalization should be for at least 3 days to avoid the complication or the re-bleeding. For those of the high risk, more than 5, those patients should have the same treatment, and then we should hospitalization. The second investigation, we can do an endoscopy. Usually endoscopy, it is done for 2 reasons, and it might be for diagnosis and at the same time for their treatment, as we talk about this later on. Sometime we can do a barium study and angiography, or a tagged RBC scan. Endoscopy, as we said, it is very important for direct visualization of the source, or it can be for therapeutic control of active bleeding, and sometimes it can be used according to the some classification we call forced classification. It will be depend on the site of the bleeding, the amount of the bleeding, amount of the vessel. So it is have a certain. This is just to know how we classified, or you hear about what is the forced classification. Usually, it will indicate whether this patient have a good prognostic factor or bad prognostic factor. These are the example of this forced classification, just to know which one of these it have very severe type of a bleeding, or it have a mild type of bleeding. Now, treatment, we have non-operative and operative. We are an internal medicine or physician. We talk about non-operative treatment. First of all, we treat the patient with peptic ulcer disease, endoscopy, and proton pump inhibitor and elimination of the H. pylori, because most of our patients have bleeding from the DU, which is the commonest cause, as we saw, of the peptic ulcer disease, which might be from the stomach. And as we know, one of the common causes of duodenal ulcer is elimination of the H. pylori. Also, endoscopic therapy, it is very important. Sometimes in severe bleeding, we can't control of the bleeding by simple measure. What we will do? We leave the patient? No. We give the patient injection of the adrenaline at the base of the vessel. We call this a sclerotherapy, or what we call sometimes we do a coagulation. For this is a bipolar electrothermal probe, or it can be give the patient argon plasma, a laser photocoagulation, or sometimes hemostatic material, including biologic glue. Some of the surgeon, they use this is in the bleeding, they put it like a gel on the glue on the bleeding side, and this will absorb the blood, and it will lead to stopping of the bleeding. Sometimes there is a non-operative measure, for example, proton pump inhibitor. How we can use this proton pump inhibitor? As we said, we can use, for example, omeprazole or pantoprazole, 80 milligram. We give it as a bolus dose. Later on, 80 milligram, 8 hourly as infusion for 24 hours. When there is a stabilization, then we'll start to decrease the patient dose to 40 milligram intravenously twice daily. Orally, we can give it, and then we can transfer the oral proton pump inhibitor for at least 6 to 8 weeks. For those patients we see in patients with peptic ulcer disease, especially the duodenal ulcer, we should eradicate H. pylori. Usually here we use on the triple therapy, we use 2 types of antibiotics, as we talked in the treatment of the duodenal ulcer was proton pump inhibitor. Usually we talk that in patient with the simple D1-RAR diagnosis with eradication of H. pylori, it usually take about 7 to 10 days. But here in those patients with bleeding, we should be for 2 to 3 weeks, and recurrent colonization 70 to 90% within a few months to years. And after that, what we will do, we do a repeated endoscopy, after 6 to 8 weeks to know whether the patient have recurrent. For those patients with portal hypertension, or those patients with esophageal viruses have a bleeding, we use a pollen tamponade, or we can use a pharmacological treatment, or by endoscopy. Usually by endoscopy, we can use what we call sclerotherapy, or we can use what we call a banding, or we can use photocoagulation and other types, as we mentioned previously. Sometimes in those patients with severe portal hypertension, we use what we call a transjugular intrahepatic portosystemic stent shunt, يسموها maneuver. Sometimes we can use another additional treatment in those patients who have a severe bleeding. We can give this patient a beta blocker, propranolol, 40 milligram twice daily if there is no contraindication to beta blocker, or we can give the patient an octreotide in form of 250 microgram as a bolus, then 250 microgram per hour infusion to decrease the gastric acid, pepsin gastric blood flow. In that case, we can stop bleeding in this patient. And there is another modality of the treatment that's include surgical treatment, and we leave this line treatment for the surgeon. Thank you very much. For any question.